There have been various massive changes in general practice in the NHS over the past couple of weeks. And in this episode, we're going to cover all of that, including the nurses' strike, the paramedics' strike, the Strep A chaos, RE hubs. If you don't know what they are, you're going to find out. And also various changes in QOF and other stuff that's been happening in general practice and the NHS. So strap in as we take in hands your primary care and learning and give you the latest update. Let's get cracking, shall we? Hello, EGP learners, and welcome to this session as we're giving you the biggest update I think we've had for a while in terms of basically news in general practice. And it's been absolutely chaotic, hasn't it, Andy?
Yeah, you're full of beans and enthusiasm this morning, Gandhi. I applaud you. It's been a difficult few weeks and months. Lots going on. Just when we thought that things were settling down as we had a new prime minister, new chancellor, new health secretary, bedding in other things in the health service and in the country have been ramping up, I guess. Really excited to talk about these things this morning. Yeah, but how are you, Gandhi, first of all?
Ticking on, caffeinated, so that's probably why I'm a bit of a beans and all that kind of stuff. But you're right, there has been lots of interesting things happening. How are you getting on yourself, Andy?
Yeah, not too bad. It's been, it's quite grueling in practice, isn't it? Really hard work. It seems to be grinding a few people down that I work with, and even myself a little bit. But it's Saturday morning, and it's great to talk to colleagues about what's been happening. So feeling a bit more upbeat this morning. So
absolutely. And if any of our colleagues did want to jump in and join us, feel free to do so in the comments and stuff. We're more than happy to share that. And if you have been finding it chaotic, leave us a thumbs up emoji in the chat and stuff, because actually it'd be nice for us to know whether or not people are seeing the similar chaos, shall we say, that I think we've been experiencing over the past few weeks in particular. And I guess a good place to start with the chaos is probably the strikes, isn't it, Andy?
Yeah, so as we've all been hearing about, there is a cost of living crisis at the moment. Inflation is running a lot higher than it has done for the past, I think, 40 years. Inflation is running at 11.1% in October. I think it's come down a smidgen. But that means that people look at their pay packets and particularly they look at what's been happening with their pay over the past 10 plus years, particularly in the health service. And people have not really been receiving inflation matching pay rises. People are feeling poorer. It's making positions in hospitals harder to fill. People are looking at other parts of the workforce. I know we're having real difficulty recruiting receptionists right now because the workforce just isn't out there, and there's lots of options for people to work. It can be a very rewarding job in general practice, but it can be very difficult. So that's really beginning to bite. And one of the areas that it is biting is around nursing pay. And the RCN has balloted members. They have elected to take strike action, and those strikes are actually happening. And this is a really historic event in the United Kingdom. I'm not actually sure. Have nurses been on strike before, Gandhi? Do you know?
No, so the junior doctors obviously went on strike a few years back. General practice did some half-hearted attempt at it even before that. But I don't think the nurses, as far as I can remember, have had a strike, and particularly not to this level if they have. So it's going to be interesting. Obviously, we're after I think the first day was yesterday, wasn't it, Andy, at the time that we're filming this?
Yeah, I think 15th. So they're striking on the 15th and the 20th of December, I guess, just to get some facts out there. And there's a pay rise negotiating position from the RCN of 19%. These things don't always end where the union first pitches the pay rise, of course, but that's what they're pitching. As we say, strike days the 15th and the 20th of this month, possible strikes in the future if this isn't resolved. But they've been very clear from the RCN that this will not affect emergency care or life-saving or life-preserving care. And this is about routine, scheduled care within the NHS. They've been very careful to reassure the public about that. But I think we've got a few news stories queued up, I suppose.
Yep. So in terms of that, let's have a little look at what we've seen. So like you say, largest strike in NHS history. There's lots of stuff around this, and particularly on social media, there's been lots of, I think, positive engagement looking at this and how this may be from various aspects. I know I've seen loads of polls and all that kind of stuff, very much in favour of the strikes. And I think it's really important to recognise that the reason why our nurses are striking is because they just feel that the current service isn't safe, and actually they've got to this point because they've been pushed towards that point over years of successive challenges and stuff. And nobody in the healthcare service, I think, ever wants to strike. But when you're faced with the proposition that what you're currently doing is not safe, what other options do we have when all the other routes of trying to make things change haven't worked? What do you think?
Yeah, absolutely. As you say, I'd like to applaud the RCN actually, because I think they're getting the engagement fairly right, actually, in terms of with the media and with the public. There were a few examples actually. Just looking at the RCN page, I think they're presenting it quite well. And they've got some good resources actually on their webpage about the strike, about why they're striking, what they're asking for. And the tone is really interesting. There's a good video from the General Secretary and Chief Executive of the RCN on their site that explains why they're striking, and they're very much pitching this, yes, about pay, but also about conditions, and the thing that they feel compelled to do as a profession to preserve the ability of the NHS and the nursing profession to be there in the future and to continue to provide care. They talk about there being a lot of nursing vacancies that need filling, that people are drawn to careers in other areas rather than nursing, that society should value care more than it does, and that they're doing this, very much for the NHS and very much standing with the patients and asking the patients and the public to stand with them, which I think is actually very true, and also quite a smart way to pitch it as well. So I think nurses, they have. I think where the junior doctors struggled with image, I think the nurses come into this with quite a sort of strong image and identity in the public eye. We often talk about hardworking nurses, and I think that's very much how headlines have read for the past however many years. So I think they're carrying like a good position into this. So interesting. Yeah. How do you think it's been playing out, Gandhi?
I think it's been so I've been approached by a couple of media outlets asking for my opinion on this, and it's interesting that I've been honest that me personally, it's not had any direct impact yet because I've not needed to use the health service at this point. I think the impact will be for the nurses' strike. That will be in the coming days and weeks, because as you said, it's mainly on routine care that they've focused the changes to try and make sure that urgent and acute care is still preserved in some way. I think the other interesting thing is, like you say, although, yes, it's about money, I think the important thing to remember is the reason why we are so struggling in the NHS is not just about demand, but it's about the workforce retention challenge, because getting more people in to do the work takes time. It's not something you can suddenly flick a switch on. And, if you look at, for example, Wes Streeting, he's outlined his plans for Labour in terms of what they would do with the healthcare system. And it's very much, lots of big numbers. I think it was something like 7,000 extra doctors, blah, 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 all that kind of stuff. I can't remember the numbers, and apologies if I got that wrong. But very little of it talks about retention, about keeping people in the job. And actually, that needs to be the priority. And if your workforce are telling you that they can't keep doing the job because it's too stressful and they're just not earning the money to keep them in it, then actually that's the thing that needs to be fixed, because otherwise they're going to leave. And that's what we're seeing in nursing. We're seeing that in general practice. We're seeing that across the board. People are leaving because the pressures are so significant that people just don't feel they can keep doing the job safely, and they don't have the reassurance that there is that element of protection if things go wrong. And let's be clear, things do seem to be going wrong. We're going to talk about some of those things in later on in this stream in terms of what has gone wrong and stuff, and some of the responses we've seen from that. So do stick around for that. But I think you're right. They have pitched it very well in terms of focusing on this is about safety. And I think that's the important thing. This is about patient safety, that the current situation is not going to be safe. It probably isn't safe right now. And actually, if we don't do something, it's going to get even worse than what it currently is. And that's saying something in my view.
Absolutely. Just to come at it from a different direction, Gandhi. So 19%, it's quite a high number, isn't it? It seems higher than what a lot of other unions have been asking for. And I've got my own opinions, about that, but I was just wondering what you thought about that 19% figure.
So here's the thing. If you're doing a job that is, life-saving, and let's be honest, nurses do life-saving work, life-caring, and benefiting the population. And if you need to pitch it at a point that keeps people from leaving. And that's the key thing. We are seeing so many people leave because they just cannot maintain doing that work for the remuneration they're getting for it to keep their families and their personal lives stable, and balancing out the chaos that they're experiencing. And then there needs to be an increase. So yeah, 19% is a huge amount. But then look at what has actually happened under the Tories in particular over the past 10 years or so. We've actually seen stagnation. We've seen actually it going backwards, like you say, because of inflationary impact. And actually, if that had kept pace with what it should have been, then we wouldn't be seeing such a significant rise increase. They wouldn't 19%, probably 3 or 4%. But because of the direct decisions that we've had in government to not keep pace with inflation, even prior to fair enough, 11% has jumped up in the past 4 months. So why are they not asking for 11%? Well, because there's that backlog. That's the issue. And until you tackle that, there's always going to be this problem of, well, it's not enough to keep people. There is that other element. Is there an aspect they're asking for more because they know the negotiation is going to be a little bit lower? Okay, fair enough. But I don't think they're wrong. To be honest, I don't see why they're not asking for 25%. There's probably a lot of people out there who are saying, well, I've not had a 19% increase in my pay. Why should they be asking for so much? The important thing to remember is that when your pay is set beyond your control, you don't have the ability to go and do other things. And actually, people are doing that because they're walking with their feet. They're leaving to do other things because it's not enough. And when you're asked to do a demanding role that is about giving care, saving lives, and keeping people healthy, particularly in a legal system that is actually being really punitive when mistakes are happening. And we've seen that with the GMC. We've seen that in the media, how they crucify people when there are mistakes, and we're not meant to be in that type of environment. Then it kind of says, why am I bothering to do all of this stuff? And actually, that's where I do think the media has a huge amount to answer for, but also the system has an amount to answer for in terms of supporting the staff that work with them. So yeah, like I say, 25%, go for it.
Yeah, I think you're right. I mean, it's a high stakes technical job, and actually with quite a long training pathway to get to, particularly the more senior and responsible and technical nursing positions. So it compares very favorably well, but with other technical jobs in the private sector, even looking at accountancy, legal, these sorts of roles, I think it is comparable now to those sorts of roles, but it doesn't always get the status it deserves. I think with the 19%, you're right, there's an element of catch up for years of below inflationary or below average wage pay rises, and there's probably an element of over pitching, just knowing that they'll have to give a little bit of ground potentially to the government as they settle. I have some speaking to friends in the private sector, they have an interesting response to this. I've had a number of friends say, I'm not unionized where I work, say in my my programming role or my project management role in this private sector company, and the way we do it is, if we're not happy with the pay or the conditions, we move organizations, we move elsewhere. Why don't nurses do that? To which you have to say, well, where are they going to go? There's a monopoly employer essentially within the United Kingdom. So that kind of market pressure on wages that some people in the private sector think is the mechanism to maintain decent wages and pay and conditions, it doesn't really apply to these monopoly employed public sector roles like doctors to a certain degree, and definitely nursing staff. So it's led to some interesting conversations.
But then again, we are seeing that. We are seeing more people move towards delivering private healthcare. And that's, like I said, that's the issue. We are then seeing people either leaving healthcare altogether, or we're seeing them go towards private healthcare. So therefore, there's less people delivering NHS care. And then the NHS is struggling even more. And that's compounding the issues that then people think, well, I'm not getting a service, I need to go elsewhere. It's contributing to the real challenge that I think the public are seeing with the healthcare system in terms of general practice, the waits in A&E, the length of time that you're waiting for an ambulance, all those kind of things. It contributes to all of it. And as much as, you know, some of our politicians don't want to make this about pay, it is about pay. And there's always that, you know, mirror aspect of it, that when, you know, the MPs talk about their pay rises, they've given themselves year on year inflation busting pay rises. And yet when it comes to the public sector to have similar things, no, we can't afford it, can't be done, not going to happen. You know, we're going to give you a 1%, 2%, whereas we're taking 10, 11, you know, 15%, that kind of stuff and things. And it just raises that question of, yeah, that's how people feel. But also, this is the consequences of those decisions made by those in power.
I'm being devil's advocate here for a second, Gandhi. So not necessarily my opinions, but considerations that will be taking place in government are there's 600 odd MPs, for example. There are tens and tens of thousands of nurses, and actually the implication of giving them a 19% pay rise in terms of the cost to the country would be enormous. There's been estimates in the media, and I think people have picked those apart and felt that some of those estimates are over estimates. But it's really, really expensive at a time when the government is struggling to balance the books. So they are wrestling with some difficult issues there.
But then look at it from the flip side, that the number of people suffering from ill health because the health system cannot cope with the volume of people coming through and the delays in people having things like surgery, you know, various other treatments and that kind of stuff, that has a negative impact on their ability to work and function as part of society. That has a bigger drain on some of the other resources. And actually, if we could get people back into their working capabilities quicker because all the other stuff was sorted, that would actually have a positive impact on the whole financial situation, because you have more people in work, you'd have more people contributing to taxes, you'd have more people being able to do stuff. So actually, there is an argument that that part of the assessment isn't often considered by the government in that respect. And also, you know, yeah, what about the billions that have been lost on private contracts that, you know, just seem to have gone, you know, to Lord Moan, to you know, Capita, various other organisations, billions upon billions that have been wasted by the government for other reasons, and there's no view of taking some of that money back from the, you know, the money they've given. So actually, there's your funds potentially to cover some of the stuff that would actually have direct benefit for our public.
Yeah,
I'm aware I'm a bit more this side on this topic, but
no, I mean, I'm playing devil's advocate just for a bit of sport with you this morning, Gandhi, really. But I think it takes us back to where we started, really, which was actually what the RCN is saying about valuing care, you know, and how much does the country value care and the caring professions. And if that's actually what we value, then, you know, we need to put our money where our mouth is and demonstrate that value by giving them wages, you know, that work and that maintain those professions and attract and retain people within them. But impact on general practice. So what do we think the impact on us might be? It's important to note that general practice contracting is different. Nurses don't have an agenda for change contract with their GP surgeries a lot of the time. In some areas they might do. So I gather they've not been able to and have not been striking in general practice for that reason. Is that right, Gandhi?
As far as I'm aware, majority of general practice nursing staff don't strike. Community service, in terms of district nurses and stuff, that may be different. It depends on how they're contracted and what it states in their contract, and it does vary geographically because of this contracting aspect and stuff. So yes, there are differences. Obviously, yesterday was 2 days ago was the first strike day. The second one's the 20th, isn't it, Andy? I think.
Yeah, we jotted them down. I think it is the 15th and the 20th. Yeah, so next week.
And I think what's going to be interesting is obviously this dovetails very clearly with the other group of healthcare workers that are striking, which is the paramedics, because they've also identified that they're going to be striking soon, aren't they, Andy?
I've just got one more question about the nurses' strike for you.
Okay, for it. Yeah,
because, you know, another impact on general practice is, suppose they get a 90% pay rise in secondary care, there will be a lot of pressure on primary care to replicate that pay increase. And because of the way we're funded in primary care, you know, there's a flat fee. I think we got a 3.5% increase in the GMS contract last year, and I think there's a similar increase projected next year in a pre-agreed multi-year settlement for general practice funding. That's going to put a enormous amount of pressure on general practice budget and probably wouldn't be affordable. So general
Yeah.
practice would be in a really difficult position. I just wanted to make that point. There's a knock on for all those other people who are nurses in other areas and also work in the healthcare sector in other roles like doctors, pharmacists, dentists.
So I talked about it in the last live stream that we did, where the impact on the budget and the various aspects in pay increase is going to have on general practice, and actually, unless there is a similar increase in the amount of resources sent to general practices, that actually they're not going to be able to pay for even the basic wage increases that are being done in terms of minimum wage for our reception teams. Obviously, as you said, if the nurses do get a level of pay rise towards 19%, clearly our practice nurses are going to be turning around saying, well, what about us? And actually practices at this point in time do not have the finances to cover those kind of increases because they're not provided them. And it's not like a practice can turn around and say, well, I'm going to go make more money. Actually, just like, we mentioned about single monopoly kind of enterprise and stuff, general practice is beholden on NHS England in terms of the funds that it gets. We can't charge patients. We can't do other things that bring income directly into the practice easily. So actually, that's going to have a huge impact on whether or not practices can afford to pay their staff. And what's going to happen is a migration of nurses from primary care to secondary care. And that's going to mean you're going to be even harder getting an appointment in general practice.
Absolutely. No pricing power in general practice,
No.
unfortunately. But paramedics. So, I mean, a lot of these issues are going to be similar that we've articulated for the nursing strikes. So paramedics are generally employed or not employed, are unionized through Unison, GMB, and Unite, and there's been a coordinated effort by those unions to coordinate strikes for impact on behalf of ambulance crews. They will be striking on the 21st of December and the 28th of December, possible further strikes coming forwards. Not all areas affected or covered by these unions or have had successful ballots. What are your thoughts about this one, Gandhi?
So we talked earlier how the nursing strike may not have as much direct impact on noticeable patient care straight away because actually it's more the routine care that's being focused on in terms of strike action and that kind of stuff. The paramedics one, that I think is going to be different. Obviously, depending on how many of the paramedics do actually strike, this is going to significantly impact the time it takes for you to get an ambulance. Because there's going to be less people around to do the work, simple as. And an ambulance, is an urgent care service. And therefore, if you've got less staff doing that, there's not going to be as many ambulances. At a time where calling for an ambulance already is massively delayed because of the various pressures within, the healthcare service and stuff. So, I've heard many stories of people calling for a 999, cardiac suggesting ambulance. It should ideally be there in about 8 minutes, taking several hours to get there. That is absolutely not a criticism on our paramedic colleagues. I know they are working flat out as best they can. And quite rightly, they've taken a similar view from my perspective, in terms of what the nurses have done, that the current system just is not safe and they have to do something. And those negotiations have got to a point where the only option left, they feel, is to strike.
Yeah, I mean, I agree with them that the current system is close to not being safe, not safe. I don't know. I'm always careful about what I say live on the internet.
Yeah.
But there are very long waits for what sound like genuine emergencies routinely with regards to the ambulance service, and that situation just needs resolving. It's interesting that they have to. It's a more difficult line for the ambulance services to walk, isn't it? Because almost by definition, an ambulance will generally be attending an emergency. They're obviously going to still attend, higher priority emergencies. I think there was a statement that was latched onto by the media saying they may not attend falls, for example. So it's a really difficult line for the ambulance service to walk, and you can see the potential for negative headlines that undermine their negotiating position here. But but because it's difficult, it's a harder decision, and and they must have really agonized about making this decision. But I'm supportive of the action.
And we've already seen that negative image, haven't we? You know, there have been elderly patients who have been waiting 8 hours plus for an ambulance and had to have tents created over them to protect them from the elements because they can't be moved and things. You know, we've seen that negative spin come on from it, and you know that's going to happen. There's going to be a push against this. What's really interesting is the article that came out recently of one area where a letter was sent from the ICB. So this is, for those that don't know, taken over from CCGs in terms of commissioning and stuff, and saying that they want general practice to cover for the paramedics so that there's less of an impact on patient care. And I have a real issue with this because that.
Yeah. What do you think about that, Gandhi?
Well, okay, so I think that undermines the whole principle of the strike. And yes, there may unfortunately be patient harm that occurs because of the strike actions that take place. But actually, number one, even if there was the capacity for general practice to do this, what is the point of the strike then if if another area of the healthcare service comes in to, stop the impact? But secondly, and more importantly, let's be blunt, let's be clear, let's be absolutely, crystal on this. General practice does not have the capacity to do that, and more importantly, it doesn't have the skills. I am not a paramedic. I cannot do a paramedic's job,
or the equipment. Is
we don't have the equipment, we don't have the training, we don't have the skills to do what a paramedic can do. We are not transferable from one role to another. Yes, there are some similarities in terms of the ability to assess, to understand medical aspects and stuff, but I cannot do a paramedic's job. I can support them in some aspects in terms of advice and giving them clarity and information to help them make decisions. Absolutely, I do that on a regular basis with many of our paramedic colleagues. There may be times where an ambulance is not needed, and obviously, general practice can definitely help in those situations. But when you need a paramedic, you need a paramedic. Let's be blunt about that. And swapping one role for another seems to be the flavour of the month because there just isn't enough people. But we just have to be honest in the fact that that's not something that can happen, and it's not safe. I wouldn't be indemnified as a paramedic for a start. So actually, if something went wrong, it's completely on me for practicing outside of my role. And I'm pretty sure the ICBs won't help me with that. If there was a problem, I'd be left out, strung out and stuff. So
that's some really interesting perspectives there, Gandhi, because in my thinking, I hadn't really got very far past we just don't have capacity in general practice to do this. Really interesting point you make about that breaking picket line issue in terms of undermining the strike efforts by colleagues, because I hadn't really got that far. But you're absolutely right that that's what's happening, and interesting to know what the BMA's position on that would be, because that feels like a union issue. Essentially, I don't know whether they have a position on that particular request that was made.
So they have
Probably a
come out with
negative
a
one.
position statement on the nurses' strike, and they are fully supportive of the nurses' strike in terms of action. And I think there's been even some recommendations that they've made about how general practice could respond to some of those changes, but I can't remember what they are off the top of my head.
So Gandhi, thinking about other impacts on general practice. So 21st and 28th, they're coming up pretty soon, probably busy times for ambulances. What are you anticipating being effects on your practice?
So I guess key things, if I see a patient in practice or I assess a patient remotely and they potentially need an ambulance, cautioning them that this may be the delay time, and actually, do you need an ambulance or can you get yourself to the hospital directly, because you are going to have a likely longer wait than even normal, and normal is long at the moment. Being prepared in the practice if we have a potentially long wait for an ambulance because of the challenges that are there, if we have a patient that absolutely needs an ambulance transfer. And I think, cautioning people that, be aware of what the impact is going to be for yourself. So, social media posts through the practice to identify that this is going to happen. You need to be aware that this is going to be an issue. And I think, unfortunately, it is going to be a challenging few days for everyone in the NHS. It's going to be challenging for our patients. But again, I do support them in what they're doing, even if I was in a situation where I would need that service. And that's the key thing right now. I think it's really easy for us to say that because we're not right now calling for a 999 ambulance because we're worried about ourselves or somebody else. But actually, I think we need to have some collective responsibility on the fact that that's going to be a potential impact, and who knows what the future holds.
Absolutely. Yeah. I think your point about patient information is really, really important, because it still happens in practice that somebody will come to the surgery when they think they are having a heart attack or when they think they are having a stroke, because they think that the surgery can manage that and we can't.
We
And I
can't.
think there's a danger that increases as paramedics aren't available. And actually, if you think you have a real emergency, then you need to make your way to the emergency department or call an ambulance if you're unable or it's unsafe to do so. So but that's not the end of the problems that are occurring this winter. We also have Strep A, scarlet fever.
Just before we get to that, so another quick commentary,
on.
Andy. Sorry, I know it was slightly out of sync here, but in terms of the other thing that we have seen is some hospitals potentially looking at cancelling bank holiday leave for certain members of staff, and particularly the doctors and stuff, saying that we're not going to treat the bank holidays for the Christmas as a bank holiday, and as a result of that, it's being treated as a normal working day, and you'll be given a day in lieu. I think that's going to be really interesting in terms of whether or not how, particularly the Junior Doctors Association, the BMA, and that kind of stuff respond to those elements, because we will have people who've already made existing plans, were due to be working. Is this going to happen to general practice? This has happened before to general practice during the pandemic, particularly over the Easter bank holidays, that they were cancelled and treated as normal days. But actually, do we have the workforce to even do that? It's going to be really interesting to see what happens in that story, and that's one that's kind of developed overnight. So unfortunately, there's not a great deal of information about that. But again, watch this space, I think, for that particular side of things. And as you mentioned, a lot of this has been absolutely fueled by the Strep A chaos in the past 2 weeks, hasn't it, Andy?
It has, yeah. So there's been a resurgence or an increase in the number of Strep A or scarlet fever cases in the UK. So this is we're probably all aware, but this is an illness that generally affects young people, although can affect older people, can affect teenagers, but is particularly more troublesome in that younger age category. There's been more cases this year, and there have been more deaths as a result of this this year. And this is something that the media has become very aware of, and there's been a lot of reporting on this issue, which has led to a big increase in the number of concerned parents contacting GPs, walk-in centres, emergency departments, and other parts of the NHS with concerns about poorly children, essentially. And then that in turn has led to problems with the supply of antibiotics, which are normally used to treat these conditions. And in fact, supplies of antibiotics have been drying up around the country. We're having big trouble with local supply. So this has become a really big issue and a big problem. It's contributed to a lot of my colleagues looking and feeling more burnt out over the past few weeks, because we've been dealing with much longer lists on call than in our normal surgeries, triaging and assessing children whose parents are worried about them with rashes and fevers. Just lots of negative effects. Go on, Gandhi, how have you been perceiving this one?
So there has been an increased number of cases. That much is clear. It seems from the current reporting there's been a threefold increase in the number of cases on average. So I think it's 4,000 something in total, compared to it would normally be, less than that on an average year. And there's various theories around that, whether it's the immunity debt that we've seen because of COVID, whether it's down to the increased mixing that we've got because of more people being around, and obviously less attentive in terms of the impact that's had, and coughs, colds, and people wanting to mix quite rightly because of what's happened over the past few years. But actually that's led to a more rapid spread. And also, other aspects in terms of how it's communicated and stuff. You're right, it's been crap, for lack of a better definition. It has been absolutely awful in general practice. The volume of cases that we have seen is astronomical, and it's had a huge impact, not just in general practice, in the hospitals, and the pharmacy colleagues. Oh my gosh, the stress they must have been under recently with trying to source the various different antibiotics. And you're right, various parts of the country have had shortages and even lack of supply completely, despite the fact that Steve Barclay has denied that, and quite incorrectly denied that. And that's had a huge impact, I think, on patient care. I'm sure there are lots of parents out there who have understood that part of it, with having to go from pharmacy to try and find antibiotics for their children. I think it's really interesting that the numbers don't match up to necessarily the panic that's been caused by it. And I do feel the media has absolute elements to answer for that. This is clickbait. They've used it massively and they've fueled it. And as a result of that, we've had loads of patients saying, I think it's Strep A, and it clearly is not. But the panic that it's created about the worry, understandably for many parents, that they're just wanting to know that their kids are going to be okay. And actually, the media has a huge responsibility in what it's done, I feel, in terms of this, because actually it's driven that panic because it's led to clicks and it's led to money.
Yeah, I mean, media, it's this clickbait sort of pattern of media behavior that's occurred, really. They need the eyeballs for their advertisers. The BBC needs to compete for eyeballs so that it can show its relevance relative to advertising funded media outlets, and it just means you get the most sensational reporting about everything, I think, including health scares. And health scares are really, really interesting to patients because they're scary. That's the sort of stuff that gets clicks. So that whole mechanic, I think, just fuels this. Things that have been absent are, I can imagine in previous years or in future years, there might actually be a public health campaign response, or at least better efforts to get good quality information out into the media, also about when to actually worry and when you need to seek help. I think that will be interesting to see in the future.
I think that's one of the things, like you said, yeah, I think that's one of the things that's been a bit of a criticism in terms of the healthcare service, that actually it seems that the response from organisations like NHS England and Public Health has been very much bending towards driving the panic as well in some aspects, because yes, there's been a concern that there's been an increase in rates, but actually that's partly also fueled it because there hasn't been the clear information about when to be concerned for your child, rather than saying this is what you need to specifically look out for and contact the healthcare service for and do various bits. It's been, the default answer has been get your child checked, but in terms of the ability for the healthcare service at a time where it's already on its knees to respond to that hasn't been there. I think various places have tried to do their best. So I know locally in our area we've had a Strep A clinic set up, but that's had the provision of approximately 14 appointments for a population of over 300,000 patients per day. And you can just imagine that just is definitely not where
about a third of an extra appointment per GP practice in the area. So, yes. But efforts applauded, and there's a mechanism there that can be built on, and additional capacity can be brought online if there is funding and willingness from ICB and NHS England Department of Health to do that. Absolutely.
I think that takes us on to the next topic that we're going to talk about, which was acute respiratory illness hubs, or as they're now being called, RE hubs. Another acronym that we're going to, I think, be hearing a lot about in the next couple of weeks or stuff. So because of the concerns about the impact on healthcare systems, it seems the ICBs have suddenly had some winter access funding made available that they can now use specifically for tackling acute respiratory illness. So particularly children with cough, colds, respiratory impact and stuff, to try and relieve the pressure, as well as, I guess, adults and all populations, exacerbation of asthma, COPD, that kind of stuff. So yeah, apparently the funding has suddenly become available in the past 2 days, and they want clinics to start from Monday. Awesome.
Yeah, I mean, it's good. It's positive, isn't it? Actually, and I think the system has learned a lot of lessons from previous requirements to step up this sort of service, such as within the COVID-19 pandemic response, when clinical management centres or COVID hubs, were set up in lots of areas, including our own in Nottingham, and for the most part, I think worked quite well to keep those patients away from the other areas of the health service where they might infect other people and where it wasn't appropriate for them to be assessed and concentrate that care in hubs. So I think that's really positive. Part of me, Gandhi. Oh, I'm going to ask you a question.
But go for it. You go for your question, and I'll come back on my point.
Well, I'll pose something. So part of me, I always have a difficult time actually weighing up whether actually it's better to set up hubs, specific areas for these types of cases, and then you have to staff them, so you're going to be pulling staff from other places anyway, because there is a lack of staff within the system. Those staff would be seeing other patients or the same patients in a different location. And part of me always thinks, actually, what if we just funded practices to add add more capacity for dealing with this. And then those patients could be seen by the staff that know them. They'll probably make a much quicker assessment. They're aware of patients' past medical history, family dynamics, all of these things that might play a role in how those parents and children are behaving within their illness. And wouldn't that be better, at least in some areas? Or Gandhi, would that be better in those areas that are able to do that?
So my personal view is absolutely that would be more effective, because then you've got localized populations dealing with their healthcare needs. So what part of it do they need to focus absolutely more on, and being responsive to changes that happen. So we know that in winter, acute respiratory illnesses are more prevalent. There are more of them, more people suffer with them, and more people need assessing, because that's what happens every year. I tried to come in earlier on your point, and how you said that you thought it was a really positive response. My question to the system would be, we knew this was going to happen, and yet the funding has been made available 2 days ago with a view for starting a clinic in 5 days. That is a gargantuan task that many places are not going to be able to do, let's be honest, because, as you mentioned, there's no workforce to do it. There's no structure to set that up quickly. COVID clinics, assessment clinics, took a couple of weeks to set up. And that was when almost every part of red tape and bureaucracy was actively taken away, and practices could focus purely on doing that, and not maintaining the business as usual, as it's called, and stuff. None of that has happened with the RE hubs. None of that is there to try and say that actually don't focus on the routine stuff, prioritize this portion, because actually that's the biggest challenge. It is continue doing what you're doing. Absolutely, that I still feel that needs to happen, but at the same time, set up centres to try and assess these patients, which does need to happen in some way. There needs to be an additional resource to help with that, but you've got no extra workforce to do that. The funding, we're still not going to tell you exactly how much you're going to get, and none of the bureaucracy busting stuff is actually available to help do that. So actually, I think the system has panned really poorly for this, because we knew this was going to happen. We've been saying this was going to happen for weeks and for months, and it happens every year. Surely someone would have some brain cells to do that. Sorry.
Okay, here. No complaints from me about those comments, Gandhi. Absolutely agree. And I know even local people have they've thought this is going to happen, and they've had a plan in their back pocket, locally, just thinking, well, if some funding comes, then we'll be able to respond in this way. But they have
the week before Christmas, to suddenly decide actually we're going to activate that there's going to be millions of pounds worth of funding across the whole of the country available. But actually, at a time where the workforce is already on its knees, this would have been really effective a month ago, at the very least, because actually we would have been set up for Strep A clinics when it happened. We knew that acute respiratory illnesses was going to get worse. There was the writing on the wall. It was happening. With flu, we knew flu season was going to be really challenging this year, and it has been. Majority of patients I've assessed this week, so I've seen on average an additional 10 patients every single day, young kids. Out of that, only 10% have I actually needed to prescribe antibiotics for. The rest have just been acute respiratory illnesses driven by viral infections and stuff, adults as well. And the treatment is, self-care, management, observation, and comfort, rather than additional treatments and things. And actually, if that had been set up, our patients, I think, would have had a much better service beforehand, rather than straining an existing workforce that's already on its knees.
So stop being reactive, start being proactive and planning. We have people who can see this coming. So it's confusing why these things are not put in place before. There must be some interesting dynamics going on with NHS England and the Department of Health. Shall we move on to our final story, or?
Well, can I bring on Christina's comment? So I appreciate I am normally a little bit more measured than this, and I apologise to everybody that I haven't been. And I guess Christina's picked up on that and saying, get off the fence and tell us what you really think. I guess, been a little bit more blunt today, haven't I? But in addition, she's asked this question about, morning both, what are your thoughts on the ICB income protecting QOF for 2022-23? Hopefully IF will also be protected. And I guess this is something that has happened elsewhere. And the question of should we freeze QoF? So for those that don't know what that we're talking about, general practice does get some payments for doing chronic care, in particular, so that's nicknamed QoF, Quality and Outcomes Framework, and more recently PCNs have had their version of it, which is called the Investment and Impact Fund, IIF. And these are monitoring things that are done to try and improve quality of care for different aspects of healthcare, whether it's blood pressure, diabetes control, COPD, anticoagulants, various different things and stuff. And the question is, whilst we are now having to be reactive to the changes that are caused by having an inability of the workforce to cope with the situation, should those resources be protected to make sure that practice can continue to deliver service? Because if they're being asked to do the routine stuff, where does the capacity come from dealing with an acute need where the population is struggling more so with that? And it is that absolute balance between acute versus chronic care. What do you think, Andy?
Yeah, this happened a number of times during COVID, didn't it? We had QoF and IAF markers suspended during that period. There's calls to do it again, and I think actually at the moment, I think they're absolutely the right thing to do, because where the acute need is with the acute need and the acute presentations. So I absolutely agree with that, but I also think we just can't keep doing this. Also, the Health and Select Committee report that came out recently, chaired by Jeremy Hunt, now the Chancellor, did also call actually to abolish QoF and replace it with something that is more fit for purpose. And I think the fact that we keep cancelling QoF perhaps indicates that it's maybe run its course. There needs to be some mechanism for encouraging quality within primary care, but I think we need to think carefully about what we replace it with. Those are my thoughts. I think yes, and I think actually let's think a bit better about, or a bit again about what quality is. Yeah, what are your thoughts, Gandhi?
I think, well, yeah, well, interesting. QoF, I don't think necessarily as a vehicle is a negative thing. I know there are many people out there who think QoF is atrocious because it is effectively just documentation. It's have you done the work for majority of places, because most places do the work, but they don't capture that effectively, and that's where the payments come. It's have you documented what you've done, and the outcomes, rather than necessarily achieve the outcomes and stuff. And there are absolutely some aspects of QoF and the Impact Investment Fund that I think are punitive on practices and possibly even intentionally. And we've talked about some of those aspects previously in our videos. For me, the immunization stuff that's happened, it is a massive mistake by NHS England, that making that part of QoF directly, which is something that is so much more challenging to deal with, has defunded practices in challenged populations, and a result of that is an error of QoF in particular. But I do think some of aspects of it, we know that blood pressure control generally has got better because of QoF. We know that cardiovascular outcomes have improved because there is monitoring and an incentive to monitor that more effectively. That slipped a little bit because of COVID, because of the impacts of what's happened. But is it a bad thing? Not necessarily, but is it a fit for purpose thing? You're right. I don't think it is anymore. I think it needs to evolve into something different. The question is, what is that different thing? Well, yeah, that's a more challenging discussion. But right now, without those funds, many practices are going to go under in April, I think. So the question is, what's going to happen?
Yeah, I think the whole system needs to get off the back foot. Being constantly reactive and doing things like this to survive, it just indicates a system that is underfunded. Essentially, we shouldn't need to do this. We should see the acute need coming, and we should put in place additional resources to deal with it. So I think it's very sad. And in our, I'd encourage people to listen or watch our episodes on the Health Select Committee report, because we talked in a little bit more detail about this issue around is QoF fit for purpose and what might replace it in the future. And
it's interesting that some areas of the country have frozen QoF and Impact Investment Fund. So we showed that in one of the articles, didn't we? That whilst the BMA have urged that to be a national decision, there are, I think, one of the ICBs, I've forgotten which one, that has actually taken that decision to prioritise, the support for general practice and their patients by making sure that those practices have that income to rely on to pay their staff. That's what majority of QoF pays for. It pays for the staff, so that they can continue to provide and prioritise a service of need at this moment in time. So should that be a national decision? Absolutely, I agree it should be. We will wait and see whether or not NHS England have the ability or the strength to make that decision, I think. But we will find out, won't we, Andy?
We will. Let's see.
Mm-hmm.
So finally,
we're going to finish on a good note. Yeah. Well, sort of good-ish.
It is good. So
it is good.
Go on, Andy. You tell us all about the PCN Plus conference, which will be coming up later this year or next year.
So many of our EGP learners know both me and Andy are significantly involved in different aspects of things, and in particular primary care networks. We've talked about a little of that today already, and we've been running a PCN Plus course for PCN clinical primary care network clinical directors. As part of that course, we are having a conference. It was originally due to be on the 5th of January, but because of the now pending train strikes, so we talked about nurse strikes, paramedic strikes, we've now got train strikes having an impact. We've had to delay that course. It's going to be in March. If you want to have a look at some of the details of that, check out the link that's now coming up on screen. So bit.ly/PCN plus 023. It is case sensitive, so we will put the link to that down below and stuff so you can have a look at it. As I said, the date is just waiting confirmation. We'll probably have that in a couple of days for you, but it's likely to be the 1st of March. And we hope to see you there, where we'll be talking about PCNs and more detail and the future of them, because technically the PCN contract finishes in 2024. So it'd be interesting to see what the next stage of that is, and sharing some really good practice, hopefully, at that conference as well. It is both remote and face-to-face. So it's going to be a new thing for me and Andy. And we've got our colleagues, Ben Gowan from the General Practice Podcast and Tara Humphreys from the Business Healthcare Podcast, jumping in to help lead that with us, as they have been doing amazingly on the course and stuff.
And what I would say about the conference is, this is the reality of primary care networks. So this is driven by people who are or have been primary care network clinical directors, and people who support primary care networks and primary care network leadership, not necessarily driven from within the NHS. So this is about the real deal and getting the job done, which I think should be refreshing.
Absolutely. And if you do want to register, like I said, have a look at the link down below. You may not be able to necessarily register right now at this moment in time, but hopefully later on in the week. So after the 19th or whatever of December, you should be able to register. We just need to confirm the date and stuff for people. Additionally, Andy mentioned that if you do want to have a look at it, check out our episode on the Health Select Committee report, which is coming right about here, right now, I would imagine. And as always at EGP Learning, we're here to help take enhance your primary care and learning. Join us next week for our New Year episode. And we're wishing you all a Merry Christmas and a Happy New Year. And we'll catch you in the New Year.